make you.
I feel like this is a good safety net to have me not be able to share my screen. But I wanted to see if I could share. Um, are you guys able to see my screen currently that says Curbside Conversations? Awesome. Good deal. So I am really excited to announce this co-branding program between the Kansas chapter of the Commission on Cancer and the Masonic Cancer Alliance. And really, I should call it the trifecta branding because the biggest part of this is Dr. Kelsey Larson. So if any of you don't know, and I'm not sure if Dr. Larson's on the call this evening, but Dr. Larson is a breast surgical oncologist at the University of Kansas. And she is dedicated to teaching, not only teaching medical students and residents, but really is dedicated to furthering educations of even advanced surgeons throughout the state. And so, with her assistance, she has created this Curbside Conversations program in breast surgical oncology. And so, the concept of this is like a near peer program. And so, if there are any surgeons, medical oncologists, radiation oncologists, primary care physicians, anyone in the state of Kansas who potentially has a breast surgical oncology question, Dr. Larson is available to field those. So, with the assistance of the Masonic Cancer Alliance, if we scroll down there, if you want to see the QR code there, and then the website as well. And so if you scan that code, that'll take you to the system to be able to log in your information, which will then get you connected to schedule a time with Dr. Larson so that you can go over any clinical questions. This isn't anything that is an official second opinion. It's not anything that's a documented opinion on the chart. This really is kind of having a peer that you can reach out to ask any questions and just run through cases. I'll say I personally have utilized this system and it was tremendously helpful. Just kind of going through the case and looking at things that maybe if I could have done differently. Luckily, there wasn't much on that one, but it was really helpful to have that reassurance to know that I was providing quality care. So it's a fantastic program. It's a lot of Dr. Larson's time. It's a lot of the assistance of the MCA. So, of course, a huge thank you to them and for helping host this evening as well. The second introduction that I would like to do this evening is Lindsay Hensley. So Lindsay is new to us. She's waving there on the screen if everyone has it to where we can view each other. So Lindsay is the new American Cancer Society representative. So I am going to stop sharing my screen. And then I was just going to ask Lindsay if she could introduce herself briefly, and then I will move on to introducing Dr. Parker.
Yeah, hi everyone. As Dr. McAllister said, my name is Lindsay Hensley. I'm the new Associate Director of Cancer Center Partnerships at the American Cancer Society. I've been here since the middle of April, so still kind of getting my feet wet with everything, but I've been meeting with people at the University of Kansas Health System and other health systems across the metro, and I'm really excited to be here. So thank you guys so much.
Great. Thanks, Lindsay, and thanks for being here. Sorry, I have too many screens loaded up here. So, next, it's my pleasure to introduce Dr. Will Parker. And so, Dr. Parker, thank you so much for being willing to present this evening. I'm sure most of you probably know Dr. Parker, but for those of you who don't, he's a practicing urologist at the University of Kansas Health System, where he's an associate professor. He was born in Georgia and was a Georgia grad, both of the University of Georgia and then attending medical school at the Medical College of Georgia as well. He then completed his urology residency at the University of Kansas Medical Center, where I had the privilege to get to know Dr. Parker. I will admit I am older, but was fantastic to know him then. And he's just as great a guy now and always willing to lend a helping hand. So prior to joining the faculty at KU, he completed his Society for Urologic Oncology Fellowship at Mayo Clinic in Rochester, Minnesota. Now that he's a faculty member at KU, he participates in the education of residents and the clinical management and surgical procedures associated with urologic oncology. He specializes in the treatment of prostate cancer, including the minimally invasive management of prostate cancer, management of advanced, recurrent, and metastatic prostate cancer, using a multidisciplinary approach in care of prostate cancer survivors. So, without further ado, and again, in advance, thank you, Dr. Parker.
Thanks, Jen. And yes, I was a resident under Jen when she was a chief resident, so I knew her as JMac, the original shared version of of Jen. So thanks for having me. I'm going to share my screen, and if I don't share the right screen, somebody just tell me because I made that mistake earlier. We good?
That looks great.
Okay, perfect. All right. Well, again, thanks for having me. So I'm going to talk about prostate cancer diagnosis and management. This is something that I'm incredibly passionate about. For those who don't know me, the only thing I treat is prostate cancer. That's all I do now. So I'm kind of a one-trick pony, and so it is a bit of a passion for me. I also, for those who've ever listened to a lecture by me, I don't really love lecturing or giving talks so much. So if people have questions, I love interruptions. And I love more conversations as opposed to just going off the slide. So if somebody ever wants to jump in, just please do so. I don't like hearing myself talk for an hour. There we go. So I have no disclosures, as mentioned earlier. So the things that we're going to cover, I'm going to talk about. So we're going to talk about screening for prostate cancer, which is probably the bulk of what I'm going to talk about because that's the most important piece of prostate cancer in my mind. Then we're going to talk about risk stratification and then some of the different approaches that we have for localized disease, which I'm going to call potpourri because there's really just a hodgepodge of different things that have evolved here recently. So to start, we're going to talk about screening in 2024, what that looks like. So why talk about screening? The reason I'm going to talk about it is population health. So it's the most common malignancy in men. Lifetime risk in an average risk person is 1 in 8. So 1 in 8 men without a strong family history or predisposition are going to be diagnosed with prostate cancer, which is an incredible incidence when you think about it. It is the second most common cause of death in men. 35,000 men will die of prostate cancer in 2024. And the risk of death is tied almost completely to the stage at presentation. Localized screen-detected prostate cancer is almost invariably cured. So 95% of men who are diagnosed through screening survive their disease. And the second leading cause of cancer death, those 35,000 men, most of those are men who screening failed. Either they weren't screened appropriately or they were never screened. And by the time they were diagnosed, they had advanced disease. Additionally, recommendations that have come along, like the U.S. Preventive Task Force in 2012 gave this grade D harm outweighs the benefits recommendation to testing or screening for prostate cancer, has resulted in a reverse stage migration. So we were making good progress, and now we're seeing higher stage disease with lower cure rates and higher treatment-related burden, meaning even the men we cure, the way we get to cure is much worse than what it would have been if they'd been diagnosed earlier. So there's a lot of reasons to focus on screening when we start thinking about prostate cancer as a whole. This is a study that came out of SEER that looked at the impact of these recommendations. And so if you look, the top is localized prostate cancer, the bottom is metastatic prostate cancer, and it's the era leading up to 2012, and then what happened afterwards. And what we see is that while we were having this steady decline in the rates of diagnosing prostate cancer, after 2012, we had a dramatic reduction in the diagnosis of prostate cancer because we just weren't screening, but unfortunately, a fairly significant uptick in the rate of metastatic disease for men of all ages. So it didn't matter if you were young, in your early 50s, or older in your 70s or 80s, everybody experienced harm because of a reduction in screening. Now, thankfully, in 2018, the U.S. Preventive Task Force made a little bit of a pivot and said that shared decision-making is what we should be doing. So it's not harm outweighs benefits. Now it's maybe. And since that came out, there has been this slow, steady uptick in the rate of PSA testing. So maybe we'll see that inverse stage migration go the right direction again at some point in time. But at least for now, we're dealing with ramifications of screening changes. So how do we screen? Very simply, PSA. PSA is a blood test, prostate-specific antigen. It's a normal protein. It's made by the prostate. It liquefies semen so sperm can swim. So it's a very, very normal protein. It's not a harmful thing. It's not a bad thing. It's just, it shouldn't really be in the bloodstream. And so PSA is produced in really, really high quantities. If you were actually to test seminal fluid, the rate of or the PSA number would be in the tens and hundreds of thousands, where normal PSA is 1 to 2. And it's just because that's what the gland's function is. It'd be much like if you tested pancreatic fluid for pancreatase, lipase and amylase, you see really high numbers, but in the bloodstream you see really low numbers. Anything that affects the gland is going to cause PSA to rise. This is one of the flaws of PSA. So trauma, your cyclist, PSAs will go up. Infection, inflammation, notably, and really kind of a wild thing is during COVID, I saw an increase in elevated PSA referrals. So when people were going less often to physicians, I was seeing more people coming into my clinic because one thing that we uncovered is the systemic inflammatory response you get from COVID and even from things like the flu will cause the PSA to go up quite dramatically. Sexual activity causes it to go up, and then obviously cancer, which is the whole reason we use it. Now, when you think about it, or when I think about it, what the continuum looks like in screening is you have this population of men who have either an elevated PSA or are yet undiagnosed. And along the way, we make a diagnosis of prostate cancer that needs to be treated. And the only way to get there is with a biopsy. So we have a pool of people, we biopsy them, we get a diagnosis. But in reality, what it looks like is this. We do a biopsy and we find cancer sometimes, and we find either non-cancerous things or men who have very low risk disease that don't need any treatment. And that happens about 60% of the time. So men who undergo a biopsy, about 60% of the time, we find something that doesn't require any action, which you could otherwise define as an unnecessary biopsy. So current state screening, we do a lot of testing, we do a lot of invasive procedures, and the kind of output is not great. So in an ideal world, we would only biopsy men who actually have prostate cancer that need treatment and not biopsy anybody else. So the problem is that if you were going to do that, you would be able to identify who needs that biopsy before you ever did it. And as I already mentioned, it's a really common disease. So 1 in 8 men. How do you enrich a pool of patients when 1 in 8 men are going to be diagnosed? The risk is really multifactorial. You have age. As we age, the risk goes up. Family history. So men who have multiple family members with prostate cancer, also other related cancers like breast, ovarian, pancreatic, men with known genetic predispositions, BRCA. Interestingly enough, the penetrance of BRCA causing prostate cancer is so high that if somebody had probably diagnosed it in prostate cancer before they did it in breast cancer, it would have a different acronym than BRCA. There are other genetic mutations that also lead to it, like Lynch syndrome, your mismatch repair enzymes, and race. Black men are at much higher risk of prostate cancer than Caucasian white men are. But unfortunately, most cases are sporadic. So while there are risk factors that we can identify, the vast majority of them, there are no risk factors. They just have prostate cancer. So it's really hard to enrich that population. So at a population health level, there are many studies that have looked at this. There's mixed and controversial data about PSA testing. There's a US trial that was done looking at PSA screening that showed no difference in mortality. Unfortunately, it was flawed by the fact that most of the people who were in this unscreened pool of men were actually getting PSA testing. 90% of them were being screened already, so it failed. And then there's European data that shows pretty significant reductions in mortality using PSA testing. So you have these controversial datas, and you have guidelines that vary with respect to what they recommend. You have things like the American Urological Association, which is my organization, which recommends 4 testing. You have the National Comprehensive Cancer Network and the American Cancer Society, which say screen. And then you have things like the American Academy of Family Physicians, the first people who generally see these patients, that say don't screen. And so you see a lot of discrepancy in how screening should or shouldn't be done. And that has ramifications, as I mentioned earlier. So there are a couple of truths that come about because of this. So first is PSA screening does reduce mortality. So even in the US, since PSA testing became FDA approved, there's been a gradual reduction in the rate of men dying of prostate cancer. So it works. Truth too is it doesn't work well. So I've already mentioned that when we use PSA testing alone, we do a lot of things that we don't need to do in order to find the men that we actually do need to do something with. And so the goal is really, again, to only biopsy men who have prostate cancer, but how do we get there? And how we get there is with a couple of different things that we're going to talk about. And I've highlighted things I'm going to spend a fair amount of time discussing. So first is, how do we screen? When should we start screening? That's probably the biggest change that's happened in my career, period. Decision-making support tools, biomarkers, imaging, and even genetics and genomics have improved how we do this. So as I mentioned, age to start, biggest thing that's changed. I spend every talk I give, I spend at least some amount of time talking about this, whether you're ever going to treat prostate cancer or not, because all of you know men who need to be screened. And so if you look at traditional guidelines, I know this is tiny, so don't try to like zoom in and look. But traditional guidelines say you should start screening at 55. The reality is you start at 40 to 45. So this is the biggest thing that has changed. We recognize that screening needs to start earlier. If you spent time with me in clinic, you would learn a couple of things about me. One is I say almost on a daily basis how much I hate prostate cancer, which is funny since it's all I treat. And the second thing is you'll see the sheer number of men who are diagnosed with aggressive disease in their 40s, which when you look at traditional screening guidelines, those are guys that miss screening because they don't start until they're already 5 to 10 years into their cancer journey by the time they get the first PSA test. So we missed the window. So why do we do that? So the reason to start screening early is that it corrects for confounding by BPH. So BPH, benign prostatic hyperplasia, it's the reason why men go to the bathroom a lot at night as we get older. BPH is entirely an age-dependent problem. So as we age, prostates grow. PSA is proportional to the size of the prostate. So the smaller the prostate, the smaller the PSA, the bigger the prostate, the bigger the PSA. We actually use a term for it, PSA density, much like density in anything else. It's something over volume. In this case, about 10 to 15% of the volume should be what the prostate or the PSA is. To put it in context, so a normal prostate is about 20 grams in a 40-year-old. And the range is maybe 5 to 10 grams of size. By the time somebody's 60, the normal size is 40, so it's doubled. And the range is anywhere from 40 to 100. So if you think about that, PSA gets wildly variable the older men get. And the only way to account for that is to either know how big their prostate is or start before that problem starts to develop. So we've looked at this a number of times in different populations. The top study comes from the Physicians' Health Study, largely a white population, but things that come out of it, the median PSA at 40 is 0.7. And if you're over the 90th percentile, which was 1.7, there was a 35-fold increased risk of being diagnosed with prostate cancer 9 years from that PSA draw. So going back to the idea of enriching a pool of patients, if I had that baseline PSA at 40, I might be able to say, okay, well, you're really in need of screening, you're not. This was also done, thankfully, in a population in the southeastern US that was heavily enriched in Black men. And the nice thing is the numbers stayed the same. So the median and the 90th percentile were exactly the same for a Black population as a white population, but the risk was much higher. 80-fold increased risk of being diagnosed with prostate cancer at an earlier age, 5 years from their PSA draw. So there's value in doing baseline screening and incredible value in doing it in men that we know are already at a higher risk. The other reason why this is so incredibly important from a health disparity standpoint is that we know that earlier diagnosis leads to improved cure and lower treatment morbidity, meaning how aggressive I have to be with treatment is less the earlier I make the diagnosis. And because Black men are disproportionately at a higher risk for prostate cancer and at an earlier age, you can start to see how that's going to stack up to higher rates of mortality, which this is from SEER. And the top line, don't try to look at the small writing, but the top line is Black men. They have a higher rate of dying of prostate cancer at an earlier age. And so even if we're not affecting their mortality risk, if we're not screening early, we're subjecting a population of men to more aggressive treatments with higher quality of life impacts if we're not screening them early enough. So, soapbox.
Dr. Parker, can I ask you a question?
Of course.
As someone who knows nothing about prostate cancer, but understands about the screening thing. So one of the challenges that we have with breast cancer is trying to argue for people to get screening at different ages than, USPTF or whoever else has recommendations. Is that a problem too in these considerations that different societies have different guidelines, or what is the barriers to people getting that earlier test?
So yes, it is a huge problem. And the barrier is us. So maybe not me, because I believe us, but it's physicians, right? It's the primary care physicians, the first point of contact, not understanding the significance of this problem. So I do spend a lot of time on outreach talking to people. I mean, again, I'm spending some time doing this because I hope, and truly I hope, that some of you might mention this to people that you know that do primary care, because the only way to solve this problem is to get primary care physicians to understand the magnitude of what it is that happens if we don't catch prostate cancer early. And it is, I mean, it's sad when we don't catch it early. I mean, the number of men that I see in my practice, not just young men, but this is a cautionary tale. I get a number of guys, almost every clinic, who come to see me who got their first PSA once they retired. So they put off their healthcare until they retired, then they went in, they got their PSA done, and it's 60. And now I get to tell them that in their retirement years, they're going to have to live with this terrible diagnosis that I'm about to make. For record, 60 is very high.
Yeah.
And could I ask a follow-up question to that? In 2012, when you mentioned that the screening guidelines went in the wrong direction, was that something, was this SEER data, I think it was 2016 to 2020 is what's quoted on that slide. Was this not available? So was it, the typical negative biopsy rates and the morbidity of biopsy, which led them to provide guidelines that were against routine PSA checks?
Yeah, it's their recommendation was one of the most flawed arguments I've ever seen. So here's how they came to the recommendation. So the trial that I referenced earlier, the PLCO trial, prostate, lung, colorectal, ovarian trial. 80,000 men randomized to screening or no screening, and 90% of the no screening men were getting screening. So already the trial was flawed because it just compared two screened populations and showed no difference. So they said, okay, screening doesn't help. At the era that they looked at data, which they were looking at data from the 90s, around that time, we didn't understand enough about prostate cancer. And so if you were diagnosed with prostate cancer, 90% of the time you ended up getting treatment. Across the board. That's not what we do anymore. We'll talk about that in a minute. 90% of the time you ended up getting treatment. And because treatments weren't as refined, the quality of life side effects affected about a third of men. And so they made this argument, which was, if we test for PSA, you're going to undergo a biopsy. You may get diagnosed, and if you may get diagnosed, you're going to get treatment, and that treatment may cause harm, which is the same argument as saying, well, if we check a blood pressure, I may find hypertension. If I find hypertension, I'm going to start a beta blocker. And if I start a beta blocker, you're going to have a side effect. And that's a bad thing. And not really understanding that the downstream ramification is, well, that beta blocker may save their cardiovascular health, that PSA test may save their prostate cancer risk. We just had to refine how we did it. So that's how they came to the recommendation. They also didn't have any urologists on the preventive task force. So the only surgeon was a gynecologist on the committee. Everybody else was primary care or pathology. So love recommendations. Some other things that we increasingly understand, and this is something that I try to drive into the minds of the men that I see, so now not primary care physicians, but men themselves, is that screening isn't one and done. So having a negative PSA doesn't mean somebody is going to be free and clear of prostate cancer for the rest of their life. So that better study, the one out of Europe, which found some really good improvements in mortality with PSA testing, and you can see the numbers on here, but the important part was they did a deep dive and they looked at, well, what happened to these men after their initial test? If they showed up for the next round and the next round and the next round, what happened? And the reality is men who stopped showing up suffered an even higher risk of dying of prostate cancer. So, for example, on the slide, I have it there, if somebody stopped after the second round of testing, so they came in for one test, 2 years later, they came in for another, and they just didn't show up again, they were at a 10-fold higher risk of being diagnosed with metastatic prostate cancer and an almost, let me do the math, about 8-fold higher risk of dying of prostate cancer. And so it's not as simple as saying, well, your PSA checked out, so you're good to go. It's probably like colonoscopies and anything else. It's getting this idea in somebody's head that screening is a routine, repetitive screening, not one and done. So other things have changed. So that's the biggest thing that's changed. Shared decision making. So who should we be worrying about is what I've kind of subtexted this as. So there are a number of tools that we have now available to us that help us understand what prostate cancer risk actually is. I'm sure multiple disease sites have this. We have one for this. It comes from a number of trials that looked at PSA and what the risk of prostate cancer was. The nice thing is from a patient side, and I use this for men who have a hard time understanding probabilities, is a lot of these tools have visual aids that help relay what is the risk. For instance, this one, what's funny about this one, I always love it, is not just does it have the risk of prostate cancer, but it throws these little thermometers up, which represent the risk of a complication from a biopsy. So at least in a cartoon format, it gives somebody the idea of, well, what's my chance of being diagnosed with prostate cancer if I undergo screening? And like I said, there are a number of these tools available. This is just to show the variance. So this is the same scenario. I took the same set of data and just made up a patient, said, oh, well, what's the probability for a given thing? And you can see For one, for instance, with this one, there's a 7% risk of having bad prostate cancer. This one, there's a 20% risk. This one comes out of the ERSPC trial and only a 5% risk of bad prostate cancer. And so a lot of sway, but it does give people some idea of something to go off of from a risk stratification. And where I find this actually to be the most helpful is communicating back to primary care physicians. So after they send me somebody, giving them some idea of, okay, well, this is what the probability is. Now, where the kind of next level with prostate cancer screening has gone is how do we move beyond PSA? So if PSA is flawed, how do we get better? Well, we make better tests. And so we have a number of tools that are available now that help us refine an elevated PSA to know when should we be doing a biopsy. This is a table that just shows some of them. It's just to go to the point that we have a number of adjunctive tools now, some of which, the red bars, are based on PSA, some of which are PSA agnostic. I like things that aren't based on a flawed test. So if I'm going to use one of these, I use something that's not. So for instance, the top one on there is a urine-based assay. Men pee into a cup at home. They ship it off to a company that then gives me a report back that just says, is this a concern or not? And it's not based on PSA, it's based on microsomes that are shed into the urine. I'm not a fancy enough scientist to come up with this. These are what these tests look like. They're what I call up and down tests. So as opposed to having to give somebody a probability and say, okay, well, you have a 15% chance of prostate cancer. What do you want to do with this? My average patient has no clue what 15% actually means. I can just say yes or no. This is positive, this is negative. Negative, we don't worry. Positive, we got to do more. Same thing, just a risk spectrum. But again, it goes to that idea of, well, if PSA is flawed, what can we do better? We can use other tools. Where we've really taken off, though, is in imaging, which is probably a bit of a bane to everybody who does image-based surveillance and screening. So Kelsey and I probably fight for time on MRI scanners on an almost everyday basis because we're both moving in that direction. At least I assume from my understanding of MRI scanner times right now, we're both utilizing more MRIs. And this really answers the question of when should we biopsy? I saw you come off mute, Kelsey. Were you going to say something?
I was just going to say that's how I hire my nurses is who can stock the MRI schedule better. Then they can work with me. I'm like, yes to you.
I just have it pinned on a side screen so I can look at it really fast. So what are we talking about with imaging? We're talking about multiparametric MRI, so 3 Tesla magnets, which unfortunately are hard to come by. The nice thing is by using MRIs, what we've done from a disease and kind of population health level is we reduce biopsies. So a negative MRI means somebody doesn't need a biopsy because the negative predictive value of an MRI is 90%. So we can effectively rule out cancer with a scan. And in doing this, we actually detect more and more prostate cancers that need to be treated. I'm not going to bore you with the numbers, but the point is that when we look at scans, we grade scans on a scale. And the higher the grade on the scale, the more likely somebody has prostate cancer. Pretty intuitive. And that's what we do today. What this leads to functionally is some of the coolest work I get to do, in my opinion. So when we have an MRI, we have a target to biopsy, we can aim for it. This is a picture of the platform that we use, which is called Urinav, which is just a way for us to co-register an MRI with an ultrasound, which is how we guide biopsies. Transrectal ultrasounds are not diagnostic. You can't see anything. The top box or top left-hand box is what the ultrasound is on this one. If you can pick out the architecture of the prostate, you're better than I am. And so the only way to get around that is to try and find ways to fuse images together to guide biopsies. And so that's what we do a lot of today. In fact, most biopsies I do now look like this. I have a target, I aim for the target, I get a diagnosis.
And so that's you, Will, doing the biopsy. You do the MRI guided biopsies. It's not radiology. Not
radiology. This is a urology. I don't know if there are any radiologists on here. This is like our fiefdom that we are holding on to. So interventional radiology has not taken over this particular part of medicine. So we do these. Okay. Which is fun. This is my favorite. Honestly, I do a lot of things. This is the one thing I will tell patients that this isn't like a brag. This is the only thing I feel like I'm really, really good at because I get to do a lot of them and I do them all the time. And so this is my favorite part of my job. Not talking about prostate cancer. Micro ultrasound is another thing that's evolved. So if ultrasounds aren't great, we made them better. A regular ultrasound is a 7 megahertz ultrasound. We now have ultrasounds that can go to 29 megahertz, and you can actually visualize gland structure. I can see it, and I'm not a radiologist, but there's a tumor. You can see it on the film, which is not something you can do with a traditional ultrasound. What this is going to lead to, and this is where the field is moving, is lowering our reliance on imaging in the form of MRIs. So Kelsey will start to like me again because I'm taking less scanner time, because now we can actually look at the ultrasounds and do the same thing as what we would do with an MRI. All right, so if this is what the paradigm normally looks like, this is what we're moving to. So is this idea of using these other tools, we're going to lessen our rate of these non-cancerous findings and find more prostate cancer. So I'm going to get off of my screening soapbox now, and now we're actually going to talk about cancer, which I assume is what everybody thought we were going to talk about. So risk stratification in prostate cancer. Probably every clinic, I mean, again, OSP is prostate cancer. I counsel a lot of men on prostate cancer. I spend a lot of time on this one point because prostate cancer is a little unique in that we don't use traditional staging. Instead, we use risk stratification. Everybody wants to know their stage. I can't tell them off the top of my head, and all I do is treat prostate cancer because we don't use it. The reason we don't use it is that prostate cancer has this wealth of information that has nothing to do with the traditional T and M stage groups. We have PSA, so it's a biomarker. We have a cancer that's graded, and then we have all this other imaging that we use. And so we rarely stage prostate cancer in the localized setting, which probably makes cancer registrars very angry. In terms of prostate cancer, the way we grade it is with a system called the grade group system. Most people who went through medical school at some point in time learned something called the Gleason score, which is the bane of my existence. It's the math problem on the side of the screen. The reason we don't use that anymore is that the Gleason score over time has evolved, where it used to be a score that went from 1 plus 1 to 5 plus 5. Now it starts at 3 plus 3. And if you're like me, who thinks in base 10, because we were all raised as people in the United States, it's hard to think of 6 as being the lowest grade of a cancer. I have a really hard time getting people to accept that. And so instead, now we've re-stratified it with this grade group system, which makes a lot of prognostic sense, but also from a patient standpoint, it really eases the understanding of grades of cancer and why we don't need to treat all cancers, which we'll get to in just a second. So as I tell people, Gleason's for the pathologist, grade group is for the patient. So risk stratified disease. Why do we risk stratify? Again, we have all these other things. What risk stratification tells us to do is it tells us what type of imaging do we need? Do they need genetic testing? Do they need genomic testing? What do they need as far as treatments are concerned? This is what risk stratification looks like in prostate cancer. I'm not going to bore you with this, but this is what I live in every single day is this table, which tells me what should I do with somebody. To boil it down a little bit, the reality is you have 4 categories men can fall into. You have very low and low risk prostate cancer, which somebody doesn't need any imaging, they don't need any genetic testing, and the standard of care is not to treat them, but to monitor them. Then you have this category called favorable intermediate risk prostate cancer, which means no imaging, no genetics, and we can do anything. We can watch them, we can treat them, doesn't really matter. Everything's on the table. Then we have unfavorable intermediate risk where we need to do further imaging with PET scans and MRIs. Maybe they need genetics, but now we need treatment. So we can't watch them anymore. Now we have to do something. And then high and very high risk men where they need imaging, they need genetics. And more importantly, if we're going to treat them, it's not just one treatment, it's a whole host of treatments. It's a combination of things that need to be done to treat that person. Why don't we use staging? So this is the AJCC stage table. Again, don't need to really focus on it other than to say, this is where the problem lies. So active surveillance is the standard of care for men who have low risk prostate cancer, not treatment, standard of care. There is no other option that is appropriate for somebody with low risk disease. And I've highlighted in blue all the stage groups in which somebody could end up being low risk. And if you notice way down there, separated from those other guys up top, is stage 3A, where if you have a big enough prostate, because again, a PSA density, if you have a big enough prostate, you could have a low risk prostate cancer. And I could tell you, you have stage 3A prostate cancer and we're not going to treat you. That's a bit of a problem. This is the range where curative intent is the standard of care. So everything in orange is where we treat men for cure. Some striking things here is stage 4A prostate cancer, stage 4, which typically you think about as being metastatic disease, is treated with cure. So another problem, when men hear they have stage 4 prostate cancer, they get really despondent. And so that's why we don't use staging in prostate cancer. And this is where the overlap is and where there's these gray areas where you could not only have standard of care be active surveillance, you could also have standard of care be treatment. And so there's a wide range and a lot of problems with how staging is done in prostate cancer. Thank you, HACC. So main takeaways, we don't do staging, we do risk stratification because there's a lot of robust data in prostate cancer that's kind of unique and makes it different, and it guides what we do next. Speaking of what we do next, how do we treat prostate cancer? So this is obviously what I spend a lot of my time doing. Risk stratification is a bit of a problem though, and prostate cancer as a whole is a bit of a bear because the treatments are not really clean. So what do I mean by that? This is the NCCN guideline table for favorable intermediate risk prostate cancer. And you can see if you have an average person, 10 years or more life expectancy, you can do 3 things. You can watch them, you do radiation, you do surgery. The first thing I'd call your attention to, this isn't like choosing between 3 different chemotherapy regimens where somebody knows that the treatment is going to be an infusion over some amount of time, and the side effects may vary based on the regimen, but they're all infusions. Now we're talking about somebody has 3 different paradigms of treatment: no treatment, radiation, or surgery. And the other thing that I think is really, really distressing for patients is this. The word preferred really doesn't exist in prostate cancer. There is no right answer and there is no one way to treat it that has the best outcome because all outcomes are pretty well equal. So from a decision-making standpoint, prostate cancer is a problem. So what can we do for prostate cancer? There are a number of things we can do. We can do active surveillance, we can do focal therapy, we can do surgery, we can do radiation. In reality, this is what it looks like. You could do risk-adapted active surveillance, so you could intensify or de-intensify it. You do focal therapy, which could be primary or salvage. Surgery is a menu. It's like an a la carte deal. It could be upfront. It could be post-radiation. It could be open. It could be robotic. It could be nerve-sparing, non-nerve sparing. There are standard approaches, RETC sparing. It's a host of things. And then you have radiation, which is the acronym soup of the century. You have radiation by itself. You have radiation with hormone therapy. You have combinations of radiation. It could be external beam, EBRT, which also goes by IMRT or IGRT. You could have stereotactic body radiotherapy or SBRT, brachytherapy, proton therapy. It's a host of things. It is a soup. Now, I am not a mean person, and so I'm not going to talk about all those things. What I'm going to try to do is just highlight some of the things that I think are unique and new in prostate cancer, things that are kind of evolving forefronts of the science as far as how we treat the disease, and some things that I think are important for anybody to know who knows a man who may ever be diagnosed with prostate cancer, because there are a couple of nuances to this where men can actually get fairly significantly harmed if they're not aware. So that's what we're going to talk about. First, I'm going to take a sip of my coffee. And yes, I drink coffee all day long. So active surveillance. So active surveillance is for a cancer that does not behave like a cancer. What active surveillance is monitoring for men who have very low risk, and favorable intermediate risk prostate cancers. It consists of PSA testing, periodic MRIs, and then biopsies. So that's the reason I highlight this is that the mainstay and backbone of active surveillance is we do biopsies and we do them periodically. For lower risk men, we do them every 12, or we do it at 12 to 18 months at first, and then every 2 to 4 years. And then for favorable intermediate risk men, where the risk is a little bit higher, we do yearly biopsies through at least 5 years, and then we start to negotiate on the frequency. If you know anybody who's been through a prostate biopsies are not things that men particularly enjoy. And so this is probably the biggest bear as far as active surveillance is concerned, is getting acceptance to the fact that biopsies are going to be required. So why do we do active surveillance? Here's the reason why. Without treatment, if I do nothing for a man who has very low risk prostate cancer, there's a 99% chance they're not going to die of disease. So do nothing, 99% of the time, they're going to outlive their cancer. Additionally, if I do nothing, at 15 years, only 3% of men with low risk disease will metastasize. and only 14% of men with favorable intermediate risk disease will metastasize. So left unchecked, it's very rare that these cancers go on to become incurable. And the freedom from reclassification or treatment is 75% for men with low risk disease and 50% for men with favorable intermediate risk disease. So it's a way to potentially avoid needing invasive procedures with very little cost, meaning from a cancer standpoint, they're not losing, they're just buying themselves time. Now, this is from the lay press. So the top is from the Wall Street Journal, the bottom is from the Associated Press. The Wall Street Journal one is one that caused me a lot of headaches a few months back. This was an editorial written by a urologist out of the University of Chicago. His name's Scott Pegner, who is a great urologist, a really smart guy. He does practice a little bit of ivory tower medicine, and so I don't think he necessarily understands some of the ramifications of what he's suggesting. But the important thing is that this idea that low-risk prostate cancer doesn't behave like a cancer is starting to gain some traction in the idea of maybe we should just stop calling it cancer. If it doesn't spread, if it doesn't kill men, why attach that name cancer? Cancer scares men. Cancer leads to overtreatment. Cancer leads to stress and anxiety and all sorts of other ramifications. And so there's this ongoing push to rename low-grade prostate cancer something else. Why wouldn't you do active surveillance? It requires repeat biopsies, so men have to be willing to accept that. And then there is one small caveat to active surveillance, which is if your cancer gets bad enough, so if it goes from a low risk or maybe a favorable intermediate risk patient to something unfavorable, suddenly the treatment now gets to be more morbid. Now we have to start adding things to the regimen, particularly with radiation. We have to add hormonal deprivation, so medications to block testosterone. And so there can be a little bit of a loss, though the risk is very small. Focal therapy. Focal therapy, as far as treatment is concerned, is the biggest advancement that has happened in the last 5 years with prostate cancer. Again, with localized disease specifically, this is the biggest advancement. Focal therapy is something that if you had talked to my original chair of urology, Dr. Thrasher, for those who knew him back before he retired, me giving a lecture about focal therapy probably would have gotten me kicked out of the program as early as 10 years ago. Focal therapy had a pretty bad name in prostate cancer because the idea was if you have cancer, your whole prostate must be bad. And so we must treat the entire prostate. And we've evolved a little bit, thankfully. And so now we have this other treatment which fills a gap that I'm going to talk about. So there's a dilemma in these favorable risk prostate cancers. And the dilemma is that we know that there are men on one end of the spectrum that don't need anything done, right? The low risk guys were active surveillance as standard of care. The men who are really old and frail, who don't have a lot of life expectancy, don't need treatment. Easy. Then we have men who have very aggressive disease or have a very long life expectancy where maybe you'd say, nope, definitely need treatment. Pretty clear cut. We know we need to do that. But then there's this kind of middle problem. So to graph this out, and I'm not an artist, so anybody who's a graphic designer and wants to make this look better, I'm all ears. I did this myself, so don't judge me. If you think about the disease severity as being related to prostate cancer mortality, as it gets worse, the risk of mortality goes up over time. Similarly, with age, as age increases, the risk of dying of something else goes up. And you can see those curves separate pretty quickly. So if you take a low-risk man or somebody who's advanced age, there's a discrepancy between those numbers. Easy, we watch them. If they're a younger man, they have more aggressive disease, discrepancy in the opposite direction. Now we need to treat them. But there's this area of the curves where there's a lot of overlap, and we don't really know what to do, right? Maybe it's similar in terms of risk benefit. What do we do with those guys? And so it's men who either have a high risk of prostate cancer mortality, or excuse me, men who don't have a high risk of prostate cancer mortality who want treatment, or men who have a risk of mortality but don't want to have radical treatment, or men where that risk is very balanced, represent this area of diagnostic or therapeutic dilemma. What do we do? If you add to that the fact that now that we use a lot of imaging, we're finding a lot of prostate cancers that are localized to one part of the prostate. So we can identify and we can put a finger on it and say, there it is. Go back to that urinav slide I showed you earlier about how we do diagnosis. If I can put a bullseye around where their cancer is, why am I putting a big bullseye around their entire prostate? Why not just put it around where their cancer is that I can see? That's what focal therapy is. Focal therapy is a way for us to target just that part of the prostate in an ablative fashion. There are a number of ways we can do it. There's cryotherapy, irreversible electroporation, and ultrasonic ablation. Cryotherapy is a transperineal approach, so it's an ultrasound in the rectum. Probes go into the prostate. We use argon gas to generate a very cold ice ball, and then we freeze part of the prostate. Irreversible electroporation is same thing, needles through the perineum, but now we attach it to some electricity. I jokingly call this riding the lightning because the voltages that are used are in excess of 5,000 volts that are arcing across the ultrasound probes in order to poke holes in the prostate. That's where the electroporation comes from. The electricity literally zaps holes inside of cells. Somehow it's safe. I don't quite understand how. I don't do irreversible electroporation because it scares the bejesus out of me. Instead, what I use is something called high intensity focused ultrasound, or HIFU. It's a transrectal procedure. There is no transperineal needle, so nothing invasive. And what it does, it generates a very conformal, focused ultrasonic energy to one small point. And then using some robotic guidance, we can map out an entire area, press go, and then ablate the part of the prostate that has a problem. So why do focal therapy? It's non-invasive. Now, you might argue that those transperineal procedures are a little bit invasive. Certainly HIFU, it's just an ultrasound of the rectum, much less invasive. There's no downtime. Men go back to work pretty quickly. The quality of life side effects are minimal, very little incontinence, very little erectile dysfunction. So guys pop back pretty quickly to their normal level of function. The problems with focal therapy, and again, this goes to the holdouts to the Thrasher era and my original chair people eras, is that it's not curative. It's a control treatment. It's just a way of saying, well, I can see cancer here. I'm just going to treat it here, but the rest of your prostate is still at risk. The control rates are 80 to 85% at 5 years, so good control. But we still have to survey the rest of the prostate. And so we essentially moved somebody from that gray area of what do I do to now we're going to do active surveillance. So men still need periodic biopsies. They still need periodic imaging, PSAs. So it doesn't eliminate the need for further follow-up in the way that radical therapies might. The other problem with focal therapy is it is really harder. I wouldn't say really hard. It is harder to treat a focal therapy recurrence. We're a little bit more limited in what we can do, and the treatments themselves are a little bit more morbid. So for instance, as a surgeon, I hate going back in and cleaning up a focal therapy failure because of the amount of scar tissue that develops from that focal therapy treatment. That's focal therapy. Surgical advancements. So where surgery has evolved is all about quality of life. So robotic prostatectomy, first off, has become the standard. I haven't done open prostatectomy in probably now 5 years. 99% of all prostatectomies in the US are done robotically. What that's led to are shorter hospital stays, fewer complications, minimal downtime. Most men go back to work in about 2 to 3 weeks, so pretty quick. Additionally, we've had refinements in surgery that have improved the recovery with respect to sexual function and urinary health, which is, honestly, a lot of what I do from a counseling perspective has to do with this. Men are afraid of the quality of life side effects of treating their prostate cancer, as most men would be. With respect to nerve sparing, which goes to the cavernosal nerves, these are non-sensory autonomic nerves that control erectile blood flow. They are attached to the prostate. We know where they live. The more of that tissue we can save, the better the sexual function is. And so we try to spare as much nerve tissue as is oncologically appropriate. Where the evolution has become is that it used to be an all or nothing procedure. Either I saved every ounce of nerve tissue or I removed every ounce of nerve tissue. And if you think about that kind of from an electrical diagram, it'd be kind of like severing the wire between a light switch and a light bulb. If I cut out all the nerve tissue, you could flip the light switch all you want to, the light bulb's never going to come on because I've disconnected any connection it has between the impetus, I want to have an erection, and the response stimulus, which would be that blood flow going in. Now, thankfully, we have understood the anatomy more, and we can do graded nerve sparing. So we can save some, maybe not all. And in doing so, we can preserve more potential future sexual function for men than we used to be able to do. So that is a balance in favor of quality of life. The other big evolution has been for urinary control, so for continence. The evolution here is the space of red sea sparing prostatectomy. It's a newer approach. It was originally described in 2010. validated in 2013. It involves removing the prostate from underneath the bladder. In a traditional prostatectomy, what would happen is we would go in, we would take the bladder and we'd move it out of the way. We'd take it off of the abdominal wall, which is where the bladder lives. We'd separate it from all of its support structures, and then we'd take the prostate out from in front, and then we put them back together again. Diagrammatically, this is kind of what it looks like. This is zoomed in on the part of the prostate or part of the anatomy where we're working. So panel A is what a standard prostatectomy is. We take the bladder, we peel it off the pubic bone, and then we go in front and take out the prostate. A space of Retzius-sparing prostatectomy, kind of think about like changing your car oil, you're underneath everything. We leave the bladder exactly where it wants to live, and we take out the prostate from underneath and preserve all of those support structures. Where this changes is urinary control. So with a standard surgery, it would normally take 3 to 6 months for most men to become dry. And it required doing Kegel exercises or pelvic floor therapy to become dry. So it was a conscious control. With Retzius sparing, most men are dry within a week to a month, and the dryness is natural. There are no exercises required. Men just become dry. It's kind of like they were before surgery. It is really remarkable how quickly men recover their urinary control. It does come at a small trade-off because we are preserving more tissue. Oncologically, to be appropriate, we have to make sure that their anatomy supports doing this surgery without increasing the risk that we're leaving some cancer behind. But when you think about certain professions where incontinence would be a disaster, take construction workers where from a masculinity standpoint, there would be a lot of challenges with having to change pads and deal with that on a job site. This can be a real game changer for those men in improving their quality of life and in gaining acceptance to a treatment that maybe they didn't previously accept. As far as radiation, so this is the pitfalls part of this conversation. I spent a lot of time counseling men about radiation, even though I'm a surgeon. Some things that have evolved. First off, stereotactic body radiotherapy, or SBRT. The fancy word is CyberKnife. It's what's termed ultra hypofractionated radiation. It's 5 treatments given every other day for a week and a half. It's convenient. It's equally effective to standard radiation, which for prostate cancer is 27 fractions. So you really shave it down a lot in terms of time, but it's only equally effective for low and favorable intermediate risk patients. It's not studied in higher risk disease. And while it's convenient, there are some drawbacks. Because it's a higher dose on a given fraction, the rate of acute urinary side effects are a lot higher, and it's limited to men who have small prostates. Men who have larger glands can't get stereotactic radiation. In higher risk disease, again, this is that pitfall. So high risk prostate cancer kills men. There's this myth that you hear men die with, but not from prostate cancer. 20% of men with high risk disease die within 5 years of their diagnosis if they don't get treated. That's predictable. It's consistent. It's been that way for years. Surgery and radiation are equivalent treatments for high risk disease based on this principle called maximal local therapy. What maximal local therapy is a idea or a paradigm about basing a treatment around some pillar. So with surgery, what maximal local therapy is surgery, so radical prostatectomy, plus the use of radiation and hormone therapy when needed. So it's done in a sequential fashion. I take out somebody's prostate, I see what happens. If they're cured, great. If not, we move to the next thing. With radiation, because of how hard it is to re-irradiate or retreat a radiated prostate, maximal local therapy is external radiation, so that 27 sessions, plus brachytherapy, implanted radioactive seeds, plus 18 to 36 months of hormonal therapy. So again, medications like testosterone as a concurrent treatment, everything all at once. The reason this is important, and this is the kind of other public health side of my talk here. So one is screening, the other is this, is brachytherapy. So the problem that has happened over time is that radiation oncologists, where they used to do a lot of brachytherapy, they've stopped doing it. And so there are very few radiation oncologists that offer brachytherapy, which means that if somebody with prostate cancer goes and sees a radiation oncologist that doesn't do brachytherapy, what they're not ever going to learn about is brachytherapy. And so they get offered a treatment that doesn't include it. And what does that look like? So with surgery, that 85% of men are going to be cured. And from a sequential standpoint, it's about 50 to 60% of them are cured with surgery alone. And then the remainder go on to get radiation and hormone therapy, of whom 50 to 75% will be cured. And that aggregate leads to about 85%. With radiation, if you do everything, it's 85%. So if you include brachytherapy, 85% cure. If you don't, only about 60% of men will be cured. And of the 40% who are not cured, the recurrence is in the prostate. So in a remnant radiated piece of tissue. And it is really hard to treat radiated tissue. For every surgeon who has ever operated on something radiated, it's terrible. Nobody likes doing it. And so salvage prostatectomies are hard, even though that's the best data that we have for radiation recurrences. Salvage reirradiation, which can be done, is very toxic. And we can do salvage ablations, but again, it's a pretty toxic treatment when you're talking about tissue that's already been radiated. So it's very important and paramount in high-risk men that they understand that if they're getting radiation, they have to get brachytherapy. And so that's why I spend a lot of time from a public health standpoint talking to men about this idea that if you're going to receive radiation in high-risk prostate cancer, if you're not seeing somebody who does brachytherapy, you're going to be putting yourself at a much higher risk of being painted into a corner. So the final thing I'm going to talk about is concurrent use of hormone therapy. What is hormone therapy? It's medications that block testosterone. By guidelines, if you're going to do radiation, men with unfavorable intermediate risk disease and high-risk disease need hormone therapy. It's 6 months for unfavorable risk disease, 18 and 36 months for high-risk disease. The idea and the rationale behind this is that what testosterone does at a cellular level is it turns on DNA repair enzymes. That's one of the things it does. And radiation works by inducing double-strand DNA breaks. So it's a synergistic effect. If you block testosterone, then suddenly the radiation works better. Traditionally, it's given as depot injections every 3 months. The treatment lasts for the duration of the therapy, plus about 6 to 12 months of time afterwards for testosterone recovery. Unfortunately, about a third of men never recover the testosterone. So we see men who have this persistent hypogonadism after treatment that can take some time to start treating, which are really recognized. Thankfully, there are some newer agents that have evolved. There's actually an oral agent now that it's called Relugolix for whatever it's worth. That has some really compelling data about testosterone recovery, where most men recover their testosterone. Of course, one of the concerns is that if all the trials are based on a data set where testosterone recovery is variable and very long, if men recover very predictably and very quickly, is survival going to be lessened? And that we don't know yet, but that will come with time. So with that, I've talked a lot. I would love to just take questions or talk about something else. Talk about hiking, anything.
Yeah, Dr. Parker, number one, I applaud you for your day-long use of coffee. Cheers. Cheers to that.
Oh, yeah.
My second question would be, so after prostatectomy, what is the pathway of, and you probably covered it in that slide, but again, this is a whole new world for me and I don't treat prostate cancer. Who needs ADT? And then who do you refer post-prostatectomy for radiation therapy? Like,
That's good.
where
So
are
I did
those
not cover that
diagrams?
at all. So great question. What happens after surgery is we follow PSAs. So PSA, terrible test, right? Except after treatment, it's an almost perfect test because either there's a PSA or there's not. So we take out somebody's prostate, we watch their PSA. If it stays low or near undetectable, we don't do anything. If it ever starts to rise and the threshold is 0.1 to 0.2, that's when the referral happens to do radiation. Hormone therapy is never given in isolation, at least not anymore, because hormone therapy is not curative. So it does not kill prostate cancer cells whatsoever. So unless it's being given as part of a radiation regimen, we reserve hormone therapy for men who develop metastatic disease. Interestingly, the reason why is that one of the end scenarios in prostate cancer is something called castration-resistant disease, which is prostate cancer that grows despite hormonal therapy. Castration-resistant disease is an iatrogenic problem. We cause it by exposing men to hormone therapy by selection pressure, which is, I think, pure evolutionary biology. Eventually, the cancers figure out how to grow. So we used to give a lot of men ADT, and then we saw a lot of castration-resistant disease. And so now we reserve it for only when we know that's our only option.
I think one of the paradigms that's really interesting, Breast talks about prostate cancer a lot, and we have a trial opening seeking to identify the lowest low-risk people with DCIS. not make it a standard of care to not do all these things. It's interesting though to hear you talk about the surgical side and the risks of surgery as opposed to a DCIS patient of mine who's having a lumpectomy, right? So I think that is also an interesting consideration, and I'll be curious as the results of our clinical trial. Its national clinical trial closed about 3 years ago, so results will come out this year. But I think that's part of the conversation as well, right? In your area, you're saving men a lot of potential morbidity by not doing these things. In my area, for the most part, patients do great after a small lumpectomy. So it's sort of interesting the parallels and the not parallels.
Yeah, unfortunately, the prostate sits at the worst anatomic location for a cancer to develop. I mean, it's the quality of life impacts are dramatic. Erectile dysfunction, urinary incontinence, and it's a challenge. I will say my rate of uptake of active surveillance improves when I spend a lot of time talking about the perils of treatment. Men suddenly forget about the word cancer and start thinking a lot about the word erection.
Well, they probably don't put two and two together originally, right?
No.
Yeah.
No, they hear the word cancer and they think cancer.
Yeah.
Great. Are there any other questions from the group? And Dr. Parker, I just have to say kudos to you. That is, every tumor conference that I sit through listening to prostate cancer, I just think, I don't really know how this is supposed to be treated. And so you did a fantastic job of shining some light on the subject, and appreciate that tremendously. Is there any questions from the groups? And again, thank you all for attending this evening. I know it's summertime and we're in the midst of vacation and family events, but Dr. Parker, certainly appreciate your time and your involvement. These lectures are recorded, so this will be uploaded to the MCA's YouTube site, and so we can send a follow-up email with that. So if there's anyone at your institutions all of the attendees who you think would benefit from watching this or observing, certainly that link will be sent out once those are uploaded.
Dr. Parker, if others have questions after they view it, can we share your email address with them? Thank you. Not to put you on the spot in front of everybody.
I mean, it's out there everywhere. It's like probably like my social security number. I mean,
That's right.
Oh yeah, I've actually been posting all of those things everywhere.
Including his credit card number, right?
He left that one day in the operating room, so I snagged that. And he's just a great guy.
You know about my coffee habit. You've watched me brew coffee in that break room probably every Monday that we work together.
I do. I'm impressed that, and that's it's a tricky coffee machine and you can master that. So any of my loved ones, I would have you biopsy and treat their prostate cancer because I know you know your way around that very confusing coffee machine. You can do anything. All right. Well, if there's no other questions, I think we will call it for this evening. Again, Dr. Parker, thank you. Dr. Larson, thank you for attending the event this evening. I'm sorry I didn't give you a chance to talk about your curbside conversations. It's of course, a joint project between the Commission on Cancer and the Masonic Cancer Alliance, but I think all of us realize the majority of that work falls on you. And thank you for your dedication to the state of Kansas and to the Commission on Cancer, because that's an awesome program. So again, anyone in attendance, we can send that in a follow-up email, both with the QR code and the link. I would love to see that evolve for other cancer sites. Not that I will post all of Dr. Parker's information everywhere, but if we can rope you into a similar project, we'll do it. Because I think these are great things for the state. And I think everyone providing care here, it's phenomenal the amount of time that they're willing to provide to not only patients, but other physicians. So it's truly appreciated. So thank you all. And with that, I hope you all have a good night.
Thanks.